Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to the 2024 ANAwareness Week presentation of Wait and Scan, Observation for AN Patients with Dr. Matthew Carlson and Dr. Michael Link with the Mayo Clinic. You can stay up to date with ANAwareness Week and everything the ANA has to offer at anausa.org. We also hope you'll make plans to attend World Vestibular Schwannoma Awareness Day on June 22nd. You can find more information about that on our website and social media pages, Facebook, LinkedIn, Instagram, and Twitter. Our website is a great resource for so many topics that you may have an interest in. There's a search function so patients can find just what they're looking for. The ANA is here to help, so please access those opportunities. So Dr. Carlson and Dr. Link, if you'd like to turn on your camera, share your screen, and introduce yourself, we can get started.
Hey, good afternoon. My name is Dr. Michael Link. I'm a neurosurgeon here at the Mayo Clinic.
My name is Matt Carlson. I'm one of the ear surgeons here, otologists. We're excited to be able to talk on a topic that we're very interested in ourselves, just broadly on the topic of acoustic neuroma or vestibular schwannoma, but also more specifically on the topic of wait and scan or observation, just because even though it's an old concept, we think there's a lot of new data that's pretty exciting that sometimes can maybe make us rethink how we provide recommendations and how patients can rethink how they could even consider having their treatment. And so we're excited to present some of that data today. I'm going to bring our screen up here just to make sure it projects okay. Share screen. And can you, Matthew, can you confirm that the screen is showing up okay?
Yes, I can see that.
All right, great. So the title of our talk is Conducting Multidisciplinary Research, and most specifically, just this new idea or way to rethink the management during wait and scan. Primarily, we're talking of smaller tumors and the best way to consider managing those things. We don't have any relevant financial disclosures. And the three things specifically we're going to talk about is, why is this topic important in the context of today? What has changed about today that's different from 10 or 20 years ago? And how should this make us reshape our thought process in this new context? And then we're going to provide an updated understanding regarding the natural history. And when we say natural history, we mean what happens if you are diagnosed with a tumor and you don't do anything to it for a very long time? What does it just naturally do on its own? And then we're going to introduce this concept called size threshold surveillance. And it's just a fancy way of introducing, giving a term to I don't want to call it completely novel or new, but it is not commonly used. And we're going to talk about that as well. Just by way of history, vestibular schwannomas or acoustic neuromas are one of our key areas of interest. We spend a lot of time researching this, a lot of time taking care of a lot of patients, using all three management tools that we have available to us. And we don't focus on just using radiation or just using surgery or just observing everybody. We really try to tailor the patient's condition and what their goals are with what we can provide the best outcome with based on what they're seeking. So at Mayo Clinic, our first surgical resection that we could find in our records, we love history, we like looking back in our records, and the first resection we could find was in 1907, which is really the beginning of what we would call the beginning of surgery for these tumors in general. We had the third gamma knife unit installed within the United States. And really since probably 1980, we've had a really good collaboration between otolaryngology and neurosurgery, which we think enhances patient care because everybody, all of us take different skills to the table and we work together. And just to say, we also have a strong focus which aligns with this disease process in neurofibromatosis type 2. And in that sense, when we talk about multidisciplinary, we're talking about having 30 different providers from 10 different specialties contributing, because that disease not only has a vestibular schwannoma, there's many other tumors that can be involved in that disease. But that's just kind of an introduction to our team and what we do at Mayo Clinic. So if you when a person's first diagnosed with this, sometimes they know somebody that's had this before, or they've heard of somebody having this before, whether they were an actor or something else. But most people actually have never heard of this condition before. they say, wow, this must be incredibly rare. And then they go to the doctor after they've had their hearing test that shows abnormal hearing in one ear, and you get the MRI and you get the diagnosis, which is the most common pathway. You say, wow, I can't believe this. This must be really rare. And you ask the question, how common are these? And it turns out that they're much more common than we once thought. We still don't call them common, but we don't call them rare anymore. They're kind of in between. If you live over the age of 70, you have a 1 in 500 chance of getting one of these. So it's not the 1 in 100,000 or 1 in a million type diagnosis. It's actually closer to 1 in 500 if you live long enough. And that has to do with the fact that we've had better access to MRIs. The MRIs have better resolution, and we're more consistently scanning people when we find asymmetrical hearing loss. There's also more people just getting MRIs in general for research studies, or they have headaches, or they have some other seemingly unrelated condition, and then you get an MRI and you get the diagnosis. We call that an incidental diagnosis. And actually, just in Olmsted County, the number of incidentally diagnosed vestibular schwannomas is approaching 20 to 25% of the diagnoses here. So 1 in 4 people got a scan for a completely different reason, and they were found to have it. So just to say, they're not rare, they're not super common, but they're kind of in between. So that's one of the reasons why this is important. If we just treated every single tumor that we saw, the minute we saw them, we would be over-treating people because we're detecting them much more than we used to detect them. In other words, probably 20 years ago, there were many people walking around with small tumors that lived their entire life and weren't aware of it. And maybe we're all the better off not knowing that they had it because of the stress of knowledge of knowing you haven't had. And so it's just this idea, if you could diagnose more tumors, the question isn't how best to treat them. It's actually who needs treatment and who doesn't as the first starting point. So that's kind of the context we're entering this in. The diagnosis is much more common, so we probably can't treat every single person that comes in the door. This is just some of our data over time that demonstrates this. At the Mayo Clinic, we have a medical linkage system that really started in 1965 and 1966 by a neurologist. It's called the Rochester Epidemiology Project. It's one of the few ways to study population statistics and diseases in the United States. Care in the United States is relatively decentralized, which means that you could go to many different centers all over the United States for a very specific condition, as opposed to other countries where everybody with the condition almost always goes to one center, or it's a government center where all the medical systems are linked together. So in those populations, you can study things really well. In the US, there's so many different medical systems, so many different insurance carriers, so many different ways you can see a physician, that you can see how it would be hard and challenging to collect all the data well. Through this Rochester Epidemiology Project, we can track population data, and it's through that registry or through that database that we're able to determine this prevalence. So because people are getting more scans and we're diagnosing them more frequently, they're commonly smaller when they're diagnosed. They don't have to be big to be diagnosed, and people have less severe symptoms. And interestingly, the average age is getting older. You'd think, well, if you're detecting them earlier, you should be detecting it at a younger age. It turns out probably it's a mixture of people living longer. So there's more people that are 85 today than there were 20 years ago and such. And it's also that access to MRI. But there might be more than just detection, but we don't know. We don't know what we don't know, so to speak. But the interesting thing is that just overall, more people are being diagnosed. The average age is older, and people have less symptoms. And they're often incidental, which drives home this point that not everybody needs treatment right when they're seen. And some people may never need treatment their whole time they have the tumor, especially if you're diagnosed with a smaller tumor at an older age, for example. This just shows that vestibular schwannomas are becoming more common than what for conditions that used to be considered even common. It's just a point to reinforce that it's no longer a rare disease. So now I'm going to hand it over to Dr. Link, and we're going to talk about the natural history of these tumors. So what happens if you are diagnosed with a small tumor and you just keep watching it over time?
So we really got interested in this really now more than 2 decades ago, because as Dr. Carlson alluded to, in some countries, particularly the Scandinavian countries, they decided early on that all patients in their country would be seen at one center. In Denmark, for instance, that's Copenhagen. In Norway, it's Bergen. And so that allowed the central database. Of course, the population of Minnesota, where Dr. Carlson and I are sitting right now, is the exact same as the entire country of Denmark, about 5.5 million people. There's more than 300 million people in the United States, so it's not possible to centralize care as well in such a populated and geographically large country as the United States. But starting in the 1970s, in Denmark, they decided they were going to observe, not treat, any tumor less than 2 centimeters. And of course, at that time, the only way to image a tumor was a CT scan. And they followed patients for a large number of years, and they presented their data in the early 2000s. And surprisingly to all of us, they showed that for the most part, if you take all tumors together, only about 30% of the tumors showed any growth on serial CT scanning over the first 5 years of observation, meaning 70% of tumors didn't grow. And so we said, wow, I think we've been overtreating a lot of people because, of course, we know people aren't born with this tumor, right? They develop it at some point during their early to middle adulthood. The average age of diagnosis is going up, as Dr. Carlson mentioned, but for the most part, you can say it's, most people are diagnosed in their 50s. And so we certainly followed that paradigm. Initially, we said, well, we're just going to observe all small tumors. We're not going to treat them. We're going to follow them because the evidence from Denmark was so convincing. But, we found that our experience wasn't the same. We thought, boy, we're seeing a lot of patients with growing tumors. And why is that? Well, one of the reasons is the way that they define growth in the Danish study was a bit different. So they were just using a single measurement, mostly based on CT scanning. And of course, these aren't spheres or cubes. These are very complex shaped lesions. And if you do a volumetric analysis, in other words, look at the whole volume of the tumor, not just one single measurement, it turned out that more tumors than we thought were actually growing because they grow so slowly. So you look at an MRI from a year ago to an MRI now, you might say, well, it looks about the same. But when you really calculate the volume, it can be significantly different. And we consider growth a change of 20% of volume or more in a year. And what this graph is showing is just that as we followed the tumors, it was much more than just 30% were growing. In fact, more than 50% were growing. And if you follow it out 10 years, for a tumor that presents already in the cerebellopontine angle, it's about 80% actually had shown some growth. And when we look at this is called a spider plot that just looks at change in volume over the years for a large number of tumors. Each of those lines, each of those colors is a separate tumor. And what was really interesting to us is that the growth is not linear. In other words, in 1 year, maybe the tumor increases maybe up to 50% in volume, which you'd think is a big change, but then it might stay stable for a number of years, or it might increase only by 10%, and then the next year it increases by 90%. We've even seen some tumors seem to get bigger and then seem to get smaller all on their own. So the reason that graph, all those lines look like a mess is because that's exactly what patients are doing. We also thought that once we detected growth, we almost always say to patients, you should have treatment. Okay, you've got a growing tumor, you're going to live another 50 years. We don't want to let it keep growing because the risk of treatment has a lot to do with the size of the tumor. So we thought, gosh, most of the time, probably 99% of the time, if the tumor grows, we tell the patient to have treatment. Most patients listen to our advice. But it turns out we did have a significant number of patients of tumors that surprisingly grew, and then we didn't do a darn thing about it. We just continued to observe them. And we tried to figure out, well, what happened to those tumors? Did they continue to grow at the same rate? Did they stop growing? And so on. And so what these three graphs are showing is, number one, on the far left, it's showing how many tumors showed growth. So that's basically freedom from growth, and you can see it goes away as you get out 10 years. Most of the tumors, about 80% of the tumors, had shown some growth. When you looked in the middle graph at patients who had shown some growth, it turns out, again, yep, they continued to grow, but about 30% had no further growth in 10 years, which is quite remarkable. So we saw growth, didn't do anything. The next 10 years, 30% of tumors didn't grow. And then what about tumors that grew? We knew it grew. We watched it. It grew again. Well, you can see again in the very far graph, still, most of them continue to grow, but there's a small percentage that we have documented evidence, maybe 20% of tumors, have grown twice on follow-up and then haven't seemed to grow again. So it just emphasizes this point that it's a somewhat unpredictable what's going to happen with any particular tumor.
Kind of the really interesting thing, the little bit of a eureka moment is when we superimposed these plots, and basically the initial growth detection, the subsequent growth detection, the subsequent, they look exactly the same. To us, when we look at that plot, they're so close in their lineup that we would say that those plots basically look the same. So that means that the time at which a person has their tumor diagnosed is not a special time in their journey, meaning that tumor probably grew for a while and then stopped and grew for a while, many times before the tumor was initially detected. And it's going to continue to do that even after it's detected. And the time you got the MRI is a little random. We see a lot of people who come in and they say, well, I had a sudden hearing loss 5 years ago. We didn't get an MRI for whatever reason. By the way, we do recommend one if you have a sudden nerve hearing loss, not fluid, but nerve hearing loss. So you didn't get one, but you're treated with steroids and it came back. So they decided not to get an MRI. And then 2 years ago, you had another sudden hearing loss that same year. And then you got steroids and then the hearing came back. So you didn't get an MRI again. And then the third time your hearing drops out, you get an MRI. Well, it's very likely that whole time that tumor was causing those episodes of sudden hearing loss. So it just intuitively, we can say, well, it seems kind of strange that if we watch a tumor initially, in the first time it grows, we're going to say you need treatment. It's kind of silly to say that because it's been doing that for a while beforehand when we didn't know about it, and it will continue to do that for a while after we see it. So there's this idea that if you take 3 different people in parallel universes and they have the exact same tumor, but they're diagnosed at different time points, they'll have remarkably different treatment courses, which is interesting because shouldn't all people be treated the same if they have the same tumor? Or shouldn't there be evidence or best suggestion or a way we consider treating them? No, it's influenced significantly by the time it's detected. And so we thought, well, maybe it's not the time you detect it in the initial first growth that should determine if that's when you need treatment. Maybe it should be something else that works across all of these different scenarios. And we thought, well, what could that be? And we'll talk about it in a minute, but probably a size threshold is better because it's not relying on the randomness of when you got your MRI or the randomness of when we first knew that it grew, even though it grew a long time ago, many, many times before. We just didn't know about it. And so that's the idea behind this. But there's this natural, to us, when you can intuitively arrive at something and you can provide pretty strong evidence to back it up, that it feels good. There's no dissonance or disconnect. And that's kind of what we've done. We've looked at what intuitively makes sense, and the data would also support that. So we call this the paradox of the wait and scan approach. So historically, a lot of centers, including us, a lot of us would say, well, we'll observe the tumor until we see a little growth, then we're going to treat it. But all tumors grew before, and most continue to grow. So why would we, pull the trigger at that one time? So kind of a new way to think about it is all tumors grew because you weren't born with it, as Dr. Link said. And most tumors probably started and stopped growing multiple times before they were diagnosed. And following the diagnosis, most are going to continue to grow anyways, but they'll have periods of time of non-growth. There's nothing special about the day it was diagnosed. In most situations, there's nothing special about the day it was diagnosed, meaning it's been doing this for a long time. It just happened to be the day that we got the scan. And probably this is an important point. When we talk about treatment, the number one outcome predictor of treatment, if you're getting treatment at a good center, is size. So if your tumor is 4 millimeters, you have almost 100% chance of having normal facial nerve function. But if your tumor was 4 centimeters, which is massively larger than 4 millimeters, your chance of good facial nerve function goes down quite a bit if you take the whole tumor out. And so that's the point. So there's, at some point, you can have a little bit of growth and your outcome's going to be the same. Like if it grew from 4 millimeters to 8 millimeters, your outcome's probably the same in most situations. But if it grew a lot, then your outcomes start to deteriorate. So where is that tipping point in size? Where do you start to deteriorate? Where do you get to the point where you say, boy, I wish we would have treated this earlier. Now you've got a much bigger problem on your hands. Where is that tipping point? And that's what we try to look at. But just to say, this is just driving home this point, that increasingly we've gotten better at saying we should initially observe a lot of these tumors, not treat every single tumor the day it's diagnosed. But if you actually look at the number of people treated in the population, we call it treatment prevalence and treatment incidence, the number of people treated is the same as it today. Like the percentage of people in the world with a tumor is the same number today as it was 20 or 30 years ago. And this picture gets to that point. So probably before MRIs, before we had a good test to really make a diagnosis of small tumors, there were a lot of people walking around with these tumors, and probably only a third or half of them were actually diagnosed. They were diagnosed after they became pretty large and they could be seen on a CT and they caused a lot of symptoms. Almost all of those people, so everybody on the left on that diagram, it's everybody with a vestibular schwannoma. The gray ones were the people that were walking around, they didn't know they had one. The red one and the green one are ones where the people knew they had a tumor and the doctors knew they had a tumor. And you can see basically almost everybody was red. Almost everybody was treated. Now, if you flash forward in what we call the post-MRI era, or whatever you want to call it, modern era, almost everybody is diagnosed. I'm sure there's a lot of people still walking around with undiagnosed tumors, but we're diagnosing more. But what you'll see is the number of green people has increased. So we're observing more. What's more interesting than all of that is if you add up the number of red people and both of them, it's about the same number. So we're not actually more conservative overall. We feel we are because we're doing a better job with the ones we see, but we're diagnosing more also. And it's a little bit of a confusing concept, but the idea is, despite us feeling like we're more conservative, we probably truthfully are just about as good as we were a while ago. And the important thing is, there's some surgeries you do to feel better. If you have a block, if your nose is blocked and you have a septal deviation, you can get a septoplasty and you feel better. The goal of that operation is to make you feel better. There's a lot of operations like that. There are other operations that are not to make you necessarily feel better, but they're to prevent problems from getting worse and trying to keep you where you're at best. And vestibular schwannoma is in general one of those diseases. It's rare. There are exceptions. A person with actually make you feel better. But in most situations for a small, medium-sized tumor, if you take the tumor out, your hearing doesn't get better. The best it does is it stays the same, almost always. Your tinnitus doesn't usually get better. It can, but it's unpredictable. So the point is, the treatment, we're not embarking on treatment to make you feel better necessarily. It's actually to prevent problems. And this just shows that quality of life in general doesn't get better after treatment. The one exception we do see sometimes is the surgical aspect, where if you have your tumor removed, so there's a certain set of people who have a diagnosis and it really bothers them to know that they have a tumor in their head. And that's an extremely reasonable feeling, even though they know it's benign and it's not a cancer and it's not going to be life-threatening at a small size. It just bothers them to know they have it. And by removing it, that actually alleviates a lot of anxiety. So there were a subset of people that had surgery and their anxiety got better. But overall, it doesn't make balance, hearing, energy, pain, health, or any of these things better. It actually doesn't, treatment doesn't necessarily improve your overall satisfaction. So we asked a large number of people who had microsurgery, radiosurgery, or observation who could stay on those treatment courses, and if they were satisfied in hindsight. So it's one of those questions like, if you could do this again, would you have done it again? Or if you recommend it to a family member in the exact same situation, would you recommend what you did? And fortunately, most people were happy with their choice, regardless of what they chose. But overall, the number of people that were happiest were the observation group. And then radiation and microsurgery are almost identical. 85% of them said they were happy, 85 or 86 versus 96. We also looked at the number of people who, right when they were diagnosed, they got a treatment versus the number of people who were observed and then got a treatment, and the people who could start on observation, stay on observation. And interestingly enough, the people that were most happy were the people who could start on observation and continue on that. So there's a little bit of selection. It was nice that they didn't go on a treatment, probably because they didn't have a lot of growth in their tumor during that course. But just to say, in general, don't undergo immediate treatment if you have a small tumor, thinking it's going to make your symptoms better and things. Having an appearing observation is very reasonable. So again, we talked about, so just detection of growth is probably a poor trigger for getting treatment, but probably there's a better trigger for treatment.
So it gets back to this idea of sort of where is the tipping point when we're thinking about moving a patient from observation and they say, okay, it's time for surgery, or a patient who comes in and says, I want my tumor out for a variety of reasons. Is there a critical size threshold above which our results just aren't going to be as good? In other words, could you let a tumor, in a way, get to a certain size and you haven't lost anything? So you can continue on with your life as it is, knowing that there's going to be kind of a finish line, at which point we're going to say, okay, I really think you should have surgery. If we're going to operate on somebody, our goal is to cure the patient, take all the tumor out, and it never recurs in their lifetime. That's called gross total resection. We want the patient to have normal facial nerve function. And there's two ways you can look at that. One is we want the patient to wake up from the operation, normal facial nerve function, keep normal facial nerve function their entire life, or the patient wakes up and has some weakness or develops some weakness, but by several months or even up to a year after treatment, they have normal facial nerve function. And not just near normal, but truly normal facial function, what we call House-Brackman grade 1. And also this issue of course, we want to preserve useful hearing, which is the hardest of the three tasks, honestly, but we want people to still be able to use a telephone in that ear. And so surveying more than 600 of our own patients that we've operated on, we looked at, is there a cutoff in size at which we can achieve those goals? And honestly, I thought, well, we do pretty well with taking all the tumor out. I bet that'll be kind of a larger, up to a larger, maybe 2 or 2.5 centimeters. And, hearing is much difficult. So maybe that'll be, once the tumor gets above a centimeter, that'll be hard. And we do pretty well with facial nerve, maybe a couple centimeters. But what this graph shows is basically, we looked at it, a large number of tumors, very different sizes, ranging from 5 millimeters to 3 centimeters, 3.5 centimeters, 35 millimeters. And we looked at it millimeter by millimeter. At what point did we start to not get that perfect result of gross total resection, normal facial nerve function, and preserved hearing? And surprisingly, it clusters around about a 14 to 17 millimeter tumor. So we can kind of think of it as 1.5 centimeters, 15 millimeters. Once the tumor gets above that size, then it's a little bit less likely we're going to get a gross total resection, a little bit less likely the patient's going to have perfectly normal facial function, and a little bit less likely that we're going to have good hearing. And as the tumor gets bigger, you can see the curves just get worse and worse. So everything kind of clusters around 1.5 centimeters. Now, that's not to say we want everybody's tumor to get up to 1.5 centimeters before we'll offer surgery. That's not what we're saying. But the point is, we can tolerate a little bit of growth in certain patients that still have small tumors. Maybe it's a tumor in an only hearing ear, or maybe it's somebody who just could not take time off work to have treatment. Radiosurgery is a little bit of a different topic, because some of the direct surgical risks don't play out in radiosurgery because there's no incision and less manipulation of nerves and so on. So far, we haven't been able to figure out a critical tumor size yet for radiosurgery, but we're continuing to look at it. We have a great statistician who works at it, and hopefully I will say that that is more information to come in a future webinar.
So just going back to, it all comes back to the patient. It all comes back to us defining our best pathways for recommendations to give the best outcomes that meet the goals of the individual patients. And so tying this all together, when the rubber meets the road, what are we saying here? So if we say that nobody was born with a tumor and all tumors necessarily grew up to the time they were diagnosed, and following diagnosis, most continue to grow, that would either lead you to say everybody should get treatment because it's just going to continue to grow anyway. So why not treat it when it's the smallest and you're the youngest and the healthiest and everything else moving forward? Or it says, in the greater context, understanding that we're still probably over-treating people, that means that in certain situations, it gives us license to tolerate some growth. So as Dr. Link said, we are not saying that we should continue to watch all tumors when they're small. It just means that out of the many ways we think about the best treatment, it provides us even a broader perspective and flexibility in meeting the goals of the patient. So in some situations, there are circumstances where it probably makes sense to continue to watch a very small tumor that has a very low risk in general for a period of time, and even waiting a little bit probably won't change the outcome of eventual treatment. A lot of people like to think about, oh, you saved hearing or you didn't save hearing. Oh, you have normal facial nerve function. You don't have normal facial nerve function. Oh, you have great tumor control or you don't. It's not just a binary thing. It's also how long can you have those things? So if you're 70 and you could have another 20 years of life with reasonably good hearing, that's most of the rest of your life for you at that time point. So it's not just, did you save it or not? It's also prolonging function for as long as reasonably possible is another one of our goals, not just do you save it or not. So it's just to say, it's one way for us to think more flexibly about it. And this does not apply to large tumors. So we're not saying if you have a 3-centimeter tumor, you should continue to watch it over time. That would be unusual for us to recommend, or anybody to recommend something like that. And we're also not saying that everybody with a 4-millimeter tumor should watch it until it gets to 1.5 centimeters. It's just to say that in certain situations, that might be the best way to meet your goals. But oftentimes, looking at the big picture, you still would get treatment earlier. This would be a classic example of a scenario where we would say delaying the treatment was okay. So this is a patient who presented with very good hearing in the right ear. And it was actually diagnosed incidentally. So they got their scan for seemingly unrelated reasons. And very surprisingly, there was a vestibular schwannoma on the right side. And it's small. It's just in the internal auditory canal. 2 years later, we got another scan. They decided to observe their tumor. 2 years later, the tumor grew just a little bit. And some people would say, when you look at that, you can clearly see it's bigger, but it's not a lot bigger. And some people would say, well, there's been some growth there. We should consider treatment. And that would be okay, even though it's a small amount of growth. But continue to watch that would be good, especially if the patient has no symptom at all and normal hearing. And then 4 years later, you get the same scan, you get another scan, and it shows again, it grew really slowly, another 2 years. And still, they have almost no symptom of their tumor. So this is the scenario where you're prolonging their basically normalness, not having any symptom from the treatment longer. When they eventually get treatment, just say it grew a little bit more on the next one, and say they got treatment at 7 years or something like that. That was another 6 or 7 years of their life that they went on without having any symptom of their tumor or the treatment of the tumor. So in this case, you would say, a lot of people would say that's a win. So it's just, again, it's a more broad way to think about it. So why is this an appealing consideration? Again, not mandate or requirement that you observe, but why is it a nice consideration to think about? Well, it probably reduces overtreatment. Again, if we saw tumor treat tumor, so to speak, there'd be way too many tumors treated and too much morbidity from the treatment and too much expense that went into it and too much lost work on patients' ends and everything else. It also defines tumor behavior. So if you treat a tumor right when you see it, if it's a small tumor, you don't actually know if it was going to grow really fast afterwards or not, because you only have one picture of it. And there is data that says that if you have a fast-growing tumor, sometimes surgery could be better than radiation in that situation, but you lost your opportunity to know that because you intervened right away. It probably improves patient acceptance, knowing. So for most people, the worst part of their journey is the day they're diagnosed with their tumor. Everything was fine. They had a little bit of hearing loss or something else, and they get their scan, and then the doctor says that they have a brain tumor or a tumor inside the head. It's not in the brain, but it's between the ear and the brain. And for a lot of people, very understandably, that generates a lot of anxiety. If a person has a small tumor and they've been reassured it's benign and you're observing it, if you've lived with your tumor for 6 months and you found out that you haven't changed a lot, that really is helps some people just accept it and not be as anxious about having the diagnosis. You're acclimating to the diagnosis, you're becoming more accustomed to it, and you're realizing it's not something that's going to cause immediate harm, that sort of thing. There's also some physiological compensation, we think. So there's this idea that if a nerve goes out by itself and you've been able to slowly adapt to that slow change over time, often your acceptance and your tolerance and your ability to cope with it through compensation is a lot better than if your function is acutely lost. And so we often talk about that for a completely different tumor, a glomus, a jugular paraganglioma. But I think the same thing can apply for some people with hearing loss. If you have almost no hearing loss and you have an operation and you save hearing, you're very happy. But if you don't save hearing and you lose it all, that's a big change versus somebody who maybe lost it over 8 years or something. And the same thing for tinnitus. So if you have no tinnitus and you have a surgery and all of a sudden your tinnitus gets acutely worse, for many people, that's much more disruptive than a gradually progressive tinnitus. And so that's not the most important thing, but it's another factor to say that maybe there's something to this idea. And then the last thing is this rapport and trust. We like building relationships with our patients. When you come in and you see us and we're saying you don't have to have treatment right away, and we're recommending even observing it for a period of time, we hope that builds trust between you and us. It shows you that we're not just trying to give you treatment, we're trying to give you the best outcome. And that when you ultimately choose to have treatment based on the information, it was an informed decision and you weren't pushed into it. And so we believe that by initial observation for smaller tumors, it might allow you to have a greater trust in the system and a stronger belief that your treatment ultimately was warranted versus just going straight into it. And again, big picture, we're talking about smaller tumors, and we're talking about, in general, preserving some of that function. And not everybody would have this, but it gives us more flexibility. So overall, just some main talking points of this talk, just because there's a lot of data we presented. So big picture, these are the big picture items. They're not common, but they're not rare. And talking about them more and more and studying them more and more is relevant because more are being diagnosed. All vestibular schwannomas grow. People aren't born with them, so they grew beforehand, and a lot of them continue to grow. In most situations, there's nothing magical about the data diagnosis, meaning it's been behaving that way for a while, you just didn't know about it. And if you didn't do anything for a while, it probably would behave that same way, and that it would be a slow, intermittent growth with periods of non-growth. Again, we're talking about small tumors. Despite us feeling like we're proportionally treating less people and giving observation as an option, which we are, the overall number of people on this face of this earth that are getting treatment for vestibular schwannoma actually hasn't changed over 30 years. So there's this facade or fake or false feeling or belief that we're being more conservative. We're actually probably not doing any better than we ever have. And for smaller tumors, don't just think about growth as the primary trigger for treatment. Think about maybe being a little bit more flexible and thinking about the patient's overall big picture. How are their symptoms? What's their life right now? Can they have a treatment right now? Can they recover from a surgery right now? Can they take time off from work? As they're hearing really good, and they want to maintain it by observing it, even if it's slowly growing. So just being more flexible to give the best option for the patient to achieve their best outcome they could have based on their priority. And this is just a general statement that I think is always true. Most of what we do in life is because we were taught to do it that way, and things organically evolve over time. If you started over from scratch and you redesign things, we'd be doing a lot of things a lot different. And I think this is one of those things. We've very slowly learned things through the textbooks when we're in school, and we've been taught certain ways, and we almost accept that as dogma. Think more flexibly about things that you do on a daily basis, because that's how emergent innovation happens. And so we believe that this is in that category of probably this is a better way to do it. And it's a way to consider this as a new as a new paradigm, really, to give the best outcome for patients. So we'd like to thank you for giving us the opportunity to present some of this data. As you can see, when we get excited about something, we start yelling. We're not angry. We're just very excited about talking about this sort of data. We're very grateful for the patients that have entrusted us with their care. It's something we take very seriously, and it's a topic that we love.
Thanks. And yeah, we can take some questions now.
Yeah, Dr. Carlson, Dr. Link, thank you so much for that presentation. If you want to go ahead and stop sharing your screen, we'll jump into a few patient questions we have here. Some of these things you guys already touched on, but it's always nice to revisit if so. First one is we have a question from a patient who's in his mid-70s with a smaller than 2 centimeter cystic schwannoma. They have severe hearing loss, but otherwise minimal symptoms. Does the size and the fact that the tumor is cystic have any effect on observation length or treatment options they might have?
Yeah, absolutely. Both of those factors are we think, quite important. It's not common that we would observe a tumor that's 2 centimeters or greater, just because even a small amount of growth is more likely to lead to symptoms. And of course, I can say from experience, not all 59-year-olds are the same, and not all 70-year-olds are the same. And so we kind of look at, comorbidities, meaning what other health issues does a person have? What current symptoms, if there are no other symptoms besides hearing loss, it wouldn't be unreasonable to observe. But again, that's getting to our threshold where we almost always think about intervention, because we know the risk if intervention becomes necessary. The patient's going to be older, the tumor's going to be bigger. We know what that means. We used to always say, frankly, that we preferred not to treat cystic tumors with radiosurgery, but we looked at our own data. The University of Pittsburgh looked at their data, and it turns out cystic tumors do respond well to radiosurgery. So we might say, boy, we don't want it to get bigger than 2 centimeters. If you need to be on anticoagulation for a heart valve problem or something, maybe we should just do radiosurgery now, knowing the tumor's likely to respond well, and it's going to be safe at 2 centimeters, but at 2.5 centimeters, it might be more risky. Or maybe we'd say, gosh, you're really healthy, you're going to live another 30 years. Maybe we should just take it out, or take out the great majority of it, and then you don't have to worry about it. So you can see why it becomes a very personal decision. We can't say in all cases we would do X, Y, or Z. But we do take into account those factors quite a lot.
This person shares that they have a small tumor, less than 1 centimeter, that has been, they would describe it as stable to very slow growing for many years. Is there any point where they could stop having regular scans done?
That's a really good question. We both want to preface this also, all these statements, by saying there's a lot of ways you can measure a tumor. And when we say 1 centimeter or 2 centimeters, we're talking about the part in the CPA. So it's not including the IAC portion of the tumor. A 2 centimeter tumor could be 1 centimeter if you're including the IAC portion also. So just want to clarify, because it can get very confusing about, we're talking about these cut points or these thresholds, and we're actually measuring them differently. So just prefacing it with that. As far as so the tumor is very small, can you ever stop surveying it? So very interesting question. There's actually been a couple papers on that topic, one from us, one from Denmark. The Danish data would say that after 5 years, that basically people don't grow anymore. That's the old data. And then again, we had an experience where we found something different. And so we studied it, and we found that a small percentage of people who didn't grow for the first 5 years ended up having more substantial growth later. Usually it was slow growth, but it can occur later. And so we don't say, well, if you're over 75 and it hasn't grown for 10 years, you can stop getting scans. We say that you probably need scans forever, but you can increase the interval a lot as you go. So for instance, if you came in right now and you were diagnosed with a smaller tumor that was just in the IAC, and you said you want to observe your tumor, we would get another scan in 6 months. And if that stayed the same size, we'd get another scan in a year. that was the same. We'd do another 1 year, and then we'd start spacing out to every 2 years. Now, just say you followed that for a good 6 to 10 years, and there is still no growth. We would probably start spacing it out a bit more. But we would probably never just say, "Oh, don't worry about following up," because people live to over 100 these days. And if you intervene earlier on for a tumor before it gets really big, your outcome is going to be better. So we don't release people because all bets are off for how long people are going to live, and when their tumors can affect them. But in general, if your tumor is much smaller, even if it grows, you're at lower risk than if your tumor is a medium size. So we tend to follow a medium sized tumor if you're watching it a little bit closer than we would a really small tumor, because your margin or your buffer is more tight with a tumor that's already a little bit larger. So we don't stop. Some centers do, but we spread out the intervals. The number of MRIs gets a lot more spaced out. The other thing we do, when you are getting repeat scans over time, you don't need to get gadolinium every single time. So we'll stop using gadolinium after 3 or 4. Even you could do it earlier, but it makes the MRI shorter. You don't need an IV. I think you get the same information if your tumor was observed. If you have surgery, you need contrast, I think, to separate scar and things. But primarily for an observed tumor, you can oftentimes just not get IV contrast anymore. So it makes the scan, probably reduces the scan length down 20 minutes. It takes 20 minutes off the scan, removes an IV, small risk of contrast issues, very small risk of gadolinium issues. So it's the long and the short of that, I think.
And it's worth emphasizing, a non-contrast MRI scan is a zero risk test. There's no radiation involved. So from our standpoint, there's no reason not to follow people.
Great information. We have a couple here that have to do with lifestyle. Someone's asking, is it safe to get pregnant while I'm in observation?
Yeah, that's a really good question. The answer is yes. It is. We would never tell somebody that they could not get pregnant just because they had a vestibular schwannoma. Obviously, if it was a really large tumor causing hydrocephalus or so on, they would need treatment first. And if somebody has a small tumor in observation and gets pregnant, there's no contraindication to going through labor and delivery. They don't have to have a C-section, for instance. We get that question asked of us often by our OB/GYN colleagues. There is a risk, an undefined risk, that the tumor could grow faster during pregnancy. We know it happens in some patients with meningiomas, and it can happen with some schwannomas or acoustic neuromas as well. But as Dr. Carlson mentioned, we can do a non-contrast MRI and get a lot of information. As far as we know, there's no risk to the fetus with an MRI scan. So if somebody had a known acoustic neuroma and 6 months into pregnancy, they develop some new symptoms, we could get a scan without contrast and probably get very good information. So we would say there's no contraindication to pregnancy, and any potential issues that arise during pregnancy can be well managed.
Would there be any risk of a tumor growing or being hoped to grow by taking hormone replacement therapy for menopause symptoms?
That's a good question. I think that dovetails the prior question, or builds on it, in the notion that there is limited data that says schwannomas have hormone receptors such as estrogen receptors or progesterone receptors, and there is data that says that they potentially do have these receptors, but there isn't convincing data that actually accelerates their growth. So I think, based on the information we have, I would say that there is not strong data that says taking hormone replacement therapy will accelerate your risk of growth with your tumor. So I think whenever these things come up, you should just primarily look at, in general, is it good for you to take hormone replacement therapy in general, and take the tumor aspect on this, as a separate issue, and just to say that there's very, very little data to suggest that that's an issue. That shouldn't be your deciding factor at all.
And then the last question here, you talked a little bit about treatment triggers. Are there any specific symptoms that would indicate that my tumor is growing and I should go in for additional scans ahead of time?
That's a really great question. And unfortunately, the answer is, for the most part, no. So it's a bit frustrating that we see lots of patients who have tumor growth, but no new symptom at all. Their hearing stays rock solid stable, but yet the tumor grew. And we see the contra situation where the patients lose or have progressive hearing loss, but the tumor hasn't changed in size. Similar with dizziness or disequilibrium. Some people will have bouts of disequilibrium and think, oh, my tumor must be growing, but it's not. Or the tumor may grow and they may say my balance is getting better, probably because their brain is learning to compensate. The one or the two symptoms that would really make us say you need a scan sooner would be if somebody develops new facial numbness or facial pain. That's from the trigeminal nerve, which is usually being affected by the tumor pushing on it. Or if somebody developed actual face weakness, that's an extraordinarily rare event from just having an acoustic neuroma. So if somebody developed those two things, facial numbness or facial weakness, or sharp electric facial pain, I think they should get a scan sooner than planned.
Well, thank you, Dr. Carlson and Dr. Link, for your time today and everything that you've done for the ANA and your partnership with us and partnership Mayo Clinic has with us as well. And thanks to everyone who is watching as part of ANAwareness Week. And be sure to stay on anausa.org for all the upcoming Awareness Week happenings and everything else going on with the ANA.
Thanks.
Thank you.
Thanks.